how do patients that are older fit in with the clinical trials? Well, usually the inclusion-exclusion criteria, they sort of discriminate patients that are, say, about the age of 70 or 80 for sure. And thinking about how the age distribution for myeloma, what that looks like, I think that's important to keep in mind because the average age of onset is 70. So 95% of patients that are diagnosed with myeloma are 50 years or older. So 5% are in their 30s and 40s. That's a small group. And 95% are 50 and up. So about half of those patients are 50 to 70, and 70 and up is the other chunk. So it's a substantial chunk of patients that are 70 or older. And now the trials for the inclusion and exclusion criteria, they sort of kick out a lot of those patients because they may have other comorbidities or they just frankly could have a too old age to fit with the inclusion and exclusion criteria. So how do we solve this problem when we think about generating data for patients that are in the older category? I think the solution is real world data. So that would refer to a series of patients that are treated at single institutions where you collect all the data for all the patients you treat over a long period of time. And you could also use population-based databases. There are a lot of different type of epidemiology resources that can be used to look at patients' outcomes. I think it's important to keep in mind that the databases that are of that nature, they are not randomized. Patients are treated on the standard of care notes. So if you look at one therapy versus the other, you have to be cautious and careful when you interpret the results. You cannot really make claims that one therapy is better than the other because the reason that the certain therapy was given was driven by clinical decision making. So maybe the sicker patients got, say, the better therapy, or if they were too sick, maybe they got a weaker therapy. And that, of course, would bias the results. So you have to be very cautious, and you have to also state that when you write it up. But nevertheless, if you look at the overall trends for patients that are treated, say, in age groups, if you say 50 to 60, 60 to 70, 70 to 80, and so forth, if you do these types of analysis and you look at calendar time changes, and that has been done, you can see how the different age groups have continued to benefit from better drugs. I project that in the future, we will continue to see more and more improvements, probably in the older patients, because historically, the better drugs were very toxic, so they were mostly given to younger patients, and there was a huge difference in the prognosis for younger versus older patients. But with the introduction of the immunotherapies, the more modern effective therapies, they can usually be given to all the patients in an equal manner. So I think there is a much bigger room for improvement in the older patients. And I would be as bold as this. I would say, if you have a patient that's diagnosed above the age of 70, if you give optimal therapy, if there are no other comorbidities, I think in 2024 and 2025 and onwards, there's a very high likelihood that that person will have the same lifespan as an individual with the same age and gender without multiple myeloma. We are not yet at the point where we can guarantee every patient this, but I think there will be more and more patients that will not have a shortening of their lifespan in that older category. And it's pretty amazing.